Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Ever wonder how your body learns to fight off something new? A virus, bacteria. It's not just about, warding off a cold. It's this really profound learning process. And surprisingly, it has this rare but, fascinating connection to your brain and nervous system. You might be surprised by how intimately connected they actually are. Welcome to the Deep Dive, your shortcut to being well-informed. Today, we're taking a deep dive into this fascinating interplay between vaccines and your brain. We're drawing insights from the latest research in immunology, neurology, and public health. Our mission: to understand the science, put the rare risks into perspective, and clear up some persistent myths.
Exactly. And we'll be your guides today. We're exploring how vaccines train your body's defenses. We'll look closely at those extremely rare neurological hints that can occur. And most importantly, we'll put those risks into clear, compelling context, comparing them to the much, much greater dangers posed by the natural infections vaccines are designed to prevent.
Okay, so to really appreciate the neurological effects we're going to talk about, we first need to sort of lay the groundwork, understand the fundamental science behind how vaccines actually interact with our bodies. So how do they kickstart our immune system?
Right. Think of your immune system as a highly sophisticated security system. It's got two main divisions, you could say, each with its own incredible capabilities. First, there's the innate immune response. That's your rapid response team, your first responders. When you get a vaccine, this team immediately recognizes the vaccine components, we call them antigens, as something new. Specialized cells like macrophages and dendritic cells, they rush in, engulf these antigens, chop them into tiny pieces, essentially. This initial reaction creates a sort of localized buzz, releasing chemical signals called cytokines. And that can give you those common temporary side effects like a low fever or feeling a bit tired.
Okay, so that initial buzz, the inflammation.
Yeah, that initial buzz is absolutely crucial because it wakes up the second division, the adaptive immune response. This is more like your elite special forces, the part that learns, remembers, custom tailors our response. So T cells recognize those chopped up antigen fragments, coordinate a really precise attack. Then B cells, with a bit of help from T cells, start churning out specific antibodies. These are like custom-made keys for the pathogen's lock, tagging it for destruction or neutralizing it. But the real magic happens after this training drill. The vaccine mimicry is over. Your body keeps memory T cells and B cells on patrol, ready to launch a faster, stronger, more targeted counterattack if you ever meet the real pathogen down the line.
So the key takeaway here, it sounds like, is that the immune system's incredible power and specificity, while protective, is also the very reason why, in super rare cases, it might get dysregulated and affect the nervous system. That's a fascinating kind of duality. So what are the key components in the vaccines that get this intricate process going?
Well, the primary active ingredients are the antigens. Basically, that's what your body needs to recognize as foreign to build immunity against. These can be killed or weakened versions of a pathogen, maybe specific protein pieces, or even genetic instructions like the mRNA and some newer vaccines that tell your own cells to temporarily produce a viral protein.
Okay, the antigens.
Right. Now, often something else is added to the mix. Adjuvants. Think of these as a turbo boost for that initial immune response. Ingredients like aluminum salts are common adjuvants. They really enhance that early innate reaction, helping your body create an even more robust and long-lasting adaptive response. They're genuinely critical for many vaccines to work well.
That makes sense, like giving the immune system a stronger wake-up call. And I know there are different kinds of vaccines out there. Do these different sort of delivery methods interact with our bodies differently?
Absolutely. Yeah, there are several vaccine platforms, each with its own approach. You've got live attenuated vaccines like MMR or yellow fever. They use a weakened but still replicating virus. It's like a very light sparring match, right? Mimics natural infection for strong, long-lasting immunity. Then there are inactivated vaccines, like some flu shots. They use a killed pathogen. Safe because it's inert, but often need multiple doses for strong immunity.
Okay.
Then you have subunit, recombinant, and toxoid vaccines. These use only specific harmless pieces of a pathogen or detoxified bacterial toxins. Viral vector vaccines like the AstraZeneca or J&J COVID-19 ones use a harmless virus basically as a delivery truck. It carries the genetic code for an antigen into your cells. And finally, mRNA vaccines like Pfizer or Moderna for COVID-19. These are quite revolutionary. They don't contain any part of the actual pathogen. Instead, they give your cells temporary mRNA instructions to produce just one specific viral protein. Your immune system sees that protein and learns to fight it. This tech allowed for incredibly rapid development.
All right, that speed was amazing. So the insight here is that these different delivery methods, they interact slightly differently, which might explain why we sometimes see different, though still incredibly rare, safety signals tied to specific types. Now, we're all unique. How does that translate to how our individual bodies respond to a vaccine?
That's a great question, and it's a vital part of understanding vaccine response. Individual variations are common. Several factors play a role. Our genetic makeup, specifically differences in our MHC genes, major histocompatibility complex genes, means our immune cells might see and present antigen fragments slightly differently. That can lead to varied immune responses. Also, the unique balance of our immune messengers, those cytokines we mentioned, that influences things like antibody production, even the type of side effects you might experience. And critically, age and immune status are significant. Premature infants, older adults, because of something called immunosescence, the natural weakening with age might have weaker responses. Also, people with compromised immune systems, say with HIV, on chemo, or certain MS therapies might have a blunted response. And for them, live attenuated vaccines can even pose a higher risk, potentially causing actual disease if their immune system can't control that weakened virus.
Wow, okay. So we've talked about how vaccines train our immune system. Now let's explore how this powerful process, in incredibly rare circumstances, can sometimes lead to those neurological complications we occasionally hear about. How does that connection happen? What's the mechanism?
The most widely accepted, biologically plausible mechanism is something called molecular mimicry. Okay, imagine your immune system creates a wanted poster for a vaccine antigen.
Right.
With molecular mimicry, that wanted poster is so similar to a wanted poster for a self-protein in your own body, like components of the myelin sheath, that fatty insulation around your nerve fibers, that your immune cells can mistakenly attack your own healthy tissue. It's basically a case of mistaken identity by the immune system. And this mechanism, it's well established in post-infection autoimmune diseases, like Guillain-Barré syndrome, often triggered by a Campylobacter infection or rheumatic fever after strep throat.
So molecular mimicry, it's almost like accidental friendly fire by the immune system because things look too similar. That's quite a specific mechanism. Are there other ways the immune response can sort of go awry and affect the nervous system?
Yes, definitely. There are other indirect mechanisms that can contribute or amplify this effect. One is bystander activation. Picture this: a strong, localized inflammatory response from the vaccine.
Good, right. But it might inadvertently cause some collateral damage to surrounding tissue. When this happens, previously hidden self-antigens, parts of your own body, the immune system wouldn't normally see, get exposed. Now, if you happen to have dormant immune cells capable of recognizing these newly exposed self-antigens, that inflammatory environment from the vaccine could activate them, triggering an autoimmune attack.
Okay, so the inflammation itself sort of reveals targets that were hidden before. Exactly. Then there's epitope spreading. This basically describes how an autoimmune response can expand. So if initial damage occurs, maybe through mimicry or bystander activation, it exposes new self-antigens, different ones. And the immune system might then begin to target these new ones as well, broadening the attack beyond the initial mistaken target.
So it snowballs.
Actually, yeah. And finally, there's the hypothesis of autoimmune inflammatory syndrome induced by adjuvants, or ASIA. This suggests that in very, very rare cases, that potent stimulation from adjuvants, those turbo boosts we talked about, might trigger a generalized, dysregulated immune response in certain susceptible individuals, leading to symptoms like chronic fatigue or muscle pain, things like that. This particular area, ASIA, is still a topic of ongoing research and debate.
Right. And what about something more direct, like the vaccine itself somehow acting on the nervous system? Is that possible?
That's a distinct mechanism, though much less common. And it's almost exclusively associated with live attenuated vaccines. In these rare instances, the weakened vaccine strain virus itself can directly affect the nervous system. Now, this is primarily a concern for individuals with severely compromised immune systems. In those very rare situations, their body can't suppress even the weakened vaccine virus. So it might replicate unchecked, maybe even revert to a more virulent form, and directly infect the central nervous system. Class examples are things like VAPP vaccine-associated paralytic poliomyelitis from the old oral polio vaccine, or Yellen yellow fever vaccine-associated neurotropic disease, and MIBE measles inclusion body encephalitis in severely immunocompromised people after an MMR shot. Very rare, but documented.
Okay, that makes sense. It's the live replicating aspect that's key there, but only in severely weakened immune systems. And what's fascinating, as you mentioned these, is that these mechanisms probably don't operate in isolation, right? A single shot in a susceptible person could potentially trigger a cascade, where molecular mimicry starts it, adjuvant inflammation maybe amplifies it, epitope spreading perpetuates it, leading to something complex.
Precisely. It can be a multi-step process in those extremely rare cases.
Okay, now let's dig into the specific neurological conditions that have been associated, at least in reports, with vaccines. And crucially, what does the data actually tell us about how often they occur?
Right. One of the most frequently discussed is Guillain-Barré syndrome, or GBS. This is an acute immune-mediated condition. It causes rapidly progressing muscle weakness, sometimes paralysis. Historically, GBS got a lot of attention when it was linked to the 1976 U.S. swine flu vaccine campaign. The estimated risk back then was about 1 additional case per 100,000 vaccinated people.
1 in 100,000.
But decades of really robust surveillance since then show the risk of GBS after the seasonal flu shot is actually very small, and often inconsistent year to year. When an increased risk is detected, it's typically on the order of 1 to 2 additional cases per million vaccine doses given, 1 to 2 per million. And crucially, the risk of getting GBS from a natural flu infection is much, much higher. During COVID-19, the adenoviral vector vaccines, J&J and AstraZeneca, did show a small increased risk of GBS. But it's important to note the mRNA vaccines did not. And again, the risk of GBS from getting actual COVID-19 was significantly higher than from any of the vaccines.
That context is so important comparing it to the disease. What about conditions affecting the brain and spinal cord, like ADEM, acute disseminated encephalomyelitis?
Yes, ADEM. It's another rare but serious inflammatory condition. Causes damage to the myelin, that protective nerve coating in the brain and spinal cord. It typically follows viral infections, especially measles. That's a known trigger. Now, while we've seen case reports linking ADEM to various vaccines over the years, large-scale studies have consistently found no statistical association between MMR vaccination and subsequent hospitalization for encephalitis, or ADEM. The rate observed after vaccination was no different from the background rate you'd expect anyway in the population. And again, the risk of developing ADEM or encephalitis from the diseases MMR prevents measles, mumps, rubella is orders of magnitude higher. It's not even close.
Okay, that's clear. Now, something parents often worry about is febrile seizures. What's the link there, given that vaccines can cause a fever sometimes?
Right. Febrile seizures. These are actually common and generally benign, harmless convulsions in young children. They're triggered by fever itself, not directly by the vaccine substance. But because some vaccines can cause a temporary fever as part of that immune response, they are indeed associated with a small, transiently increased risk of these seizures. For instance, with the MMR vaccine, it's about 1 extra seizure for every 3,000 to 4,000 children. And that typically occurs 5 to 12 days after the first dose, when the fever might happen. A small increased risk was also noted when the inactivated flu shot is given at the same time as pneumococcal or DTaP vaccines in kids under 2. That was about 30 additional febrile seizures per 100,000 children.
30 per 100,000, okay.
But the vital context here, and this is key, the diseases these vaccines prevent, like measles and influenza, they are themselves common causes of high fever and thus significant triggers for febrile seizures. So routine vaccination almost certainly prevents far more febrile seizures than it triggers by preventing the diseases that really cause those high seizure-inducing fevers in the first place.
That's a really important perspective shift, preventing the bigger cause of fever. Now, the COVID-19 pandemic introduced a new safety signal related specifically to blood clots. Can you explain that one?
Yes, that was a significant finding. Vaccine-induced immune thrombotic thrombocytopenia, or VITT. It's a rare but serious syndrome involving blood clots combined with low platelet counts. And it was causally linked to the adenoviral vector COVID-19 vaccines, AstraZeneca and J&J. A particularly severe form is cerebral venous sinus thrombosis, or CVST, which is a specific type of stroke affecting the brain's veins. The rapid identification of VITT through global surveillance systems was actually a major success story for pharmacovigilance. It showed how quickly these systems can detect and react to new, rare signals.
Right, the system worked in finding it quickly.
Exactly. And regarding stroke more broadly, while extremely rare cases of hemorrhagic stroke were reported after mRNA COVID-19 vaccination, the risk is dramatically lower than the risk of stroke from getting natural SARS-CoV-2 infection. And here's something many people don't realize. influenza vaccination is actually associated with a significant reduction in the risk of stroke. That's a protective effect.
Wow, a reduction. Okay. What about other neurological conditions sometimes reported after vaccination? Things like Bell's palsy?
Yeah, conditions like Bell's palsy, that temporary facial paralysis, have been reported in case series after various vaccines. But large population studies generally haven't found rates higher than what you'd normally expect in the background population, so no clear link established. Then there's small fiber neuropathy that causes pain, numbness, autonomic issues, and postural orthostatic tachycardia syndrome, or POTS. These have been described in case reports following vaccination, particularly noted after HPV and COVID-19 vaccines. Now, these reports are important. They generate scientific hypotheses, they guide further research, but so far, large population-based studies have not confirmed a causal association, for example, between the HPV vaccine and POTS, or small fiber neuropathy. This definitely remains an area of active research and, frankly, ongoing public discussion and debate.
Okay, so this brings us to what feels like the most crucial part of this deep dive, putting these incredibly rare risks into context. As you said, it's really not a choice between a small risk and zero risk. It's a choice between a very small, well-characterized risk from vaccination and a much larger, often more severe, and certainly less predictable risk from getting the natural infection. Can you lay out that stark contrast for us with some key examples?
Absolutely. This is critical. Let's look at measles versus the MMR vaccine. Natural measles infection is highly neurotropic. It loves nerve tissue. It can cause acute encephalitis inflammation of the brain in about 1 in 1,000 cases. That encephalitis is fatal in 10–20% of those affected and causes permanent neurological damage in 25% of survivors. Grim numbers. Measles also causes ADEM, that demyelinating condition, in roughly 1 in 1,000 cases, and perhaps most devastatingly, measles causes subacute sclerosing panencephalitis, or SSPE. This is a rare but universally fatal progressive brain disorder that shows up years after the initial measles infection. The overall estimate is 1 in 10,000 infections, but it's as high as 1 in 5,500 for children infected when they're under age 1. Horrific.
Just terrible outcomes. Okay, now compare that to the MMR vaccine.
Right.
For the MMR vaccine, the risk of encephalitis is less than 1 to 2 per million doses. Per million. That rate is actually indistinguishable from the background rate you'd expect anyway. We can't even statistically link it. And while there's that small temporary risk of benign febrile seizures, we talked about 1 in 3,000 to 4,000 doses, they don't cause lasting damage. So the comparison, it's unequivocal. A child who gets natural measles is at least 1,000 times more likely to develop encephalitis than a child receiving the MMR vaccine. And vaccination completely eliminates the risk of that fatal SSPE.
1,000 times more likely. That's incredibly stark. What about with the flu? How do those risks stack up? Okay, influenza versus the influenza vaccine. Natural flu infection is a known significant trigger for GBS. It can also cause acute neurological issues like seizures or delirium, especially in severe cases. Moreover, getting the flu increases your subsequent risk of both types of stroke, ischemic, and hemorrhagic, and it's even been linked to a higher long-term risk of developing neurodegenerative diseases like Parkinson's and dementia. Now, contrast that with the flu vaccine. It carries that rare GBS risk we mentioned, about 1 to 2 cases per million doses when detected. But strikingly, influenza vaccination is associated with that significant reduction in the risk of stroke. Vaccinated folks show about 19% lower risk, and it's also been associated with a reduced risk of dementia. So for neurological health, the flu shot looks protective in some key ways.
Protective for neurological health, not just against respiratory illness. That's fascinating. And the COVID-19 pandemic, it gave us this real-time global comparison on an unprecedented scale. What did that tell us definitively?
The data for SARS-CoV-2 versus COVID-19 vaccines is very clear, very consistent. Natural SARS-CoV-2 infection is associated with a significantly increased risk of stroke, GBS, encephalitis, myelitis, spinal cord inflammation, and of course those persistent long COVID cognitive symptoms, brain fog, memory issues, fatigue. This risk from infection is substantial. It far, far exceeds the risk of any vaccine-related neurological event. Yes, the adenoviral vector vaccines had that rare causal link to VITT-CVST and a small GBS risk. Yes, mRNA vaccines had extremely rare cases of myocarditis and these rare reports of hemorrhagic stroke, but the overall conclusion, time and again, is consistent. The risk from the actual infection is significantly dramatically higher than any risk from vaccination.
So the pattern is crystal clear across different diseases and vaccines. Vaccination is not just protective against the main illness, but it's also a powerful tool for reducing the overall burden of neurological disease. The choice, as you emphasized, isn't risk versus no risk. It's tiny, well-monitored risk versus much larger, unpredictable, severe risk. That's a critical distinction. Now, we've looked at the general picture, but health is personal. What about considerations for specific groups? Individuals with pre-existing conditions like multiple sclerosis.
Right, good question. For patients with multiple sclerosis, or MS, preventing infections is actually a key part of their overall care plan. Why? Because infections are well-known triggers for MS relapses or flare-ups. Now, there were historical concerns, worries that vaccines themselves might cause MS or trigger relapses, but these have been definitively refuted by numerous large, well-conducted studies. There's just no credible evidence for a causal link there.
Okay, so vaccines don't cause MS. Good to be clear on that.
Absolutely. But the critical distinction for MS patients, and this is really important for them and their doctors, is the type of vaccine. Inactivated vaccines, subunit, toxoid, and mRNA vaccines, think the injectable flu shot, COVID-19 mRNA vaccines, Tdap, the Shingrix vaccine for shingles, those are considered safe. They are highly recommended even for MS patients who are on disease-modifying therapies or DMTs. However, live attenuated vaccines like MMR, varicella chickenpox, or the intranasal flu vaccine Flumist, these are generally contraindicated. They're usually avoided for MS patients taking immunosuppressive DMTs. The reason is that small but real risk that the weakened vaccine virus could cause an infection if their immune system is suppressed by the MS medication. So if a live attenuated vaccine is absolutely required, it should ideally be given at least 4 to 6 weeks before starting that immunosuppressive therapy. And vaccination should also generally be delayed during an acute MS relapse.
Okay, so careful planning around vaccine type and timing is key for MS patients on certain therapies. And this naturally leads us to a broader societal concept, doesn't it? Herd immunity.
Exactly. The guidance for MS patients really applies to all immunocompromised individuals, people undergoing cancer treatment, organ transplant recipients, those with primary immunodeficiencies. They are all at that small but real risk from live attenuated vaccine strains. And this just underscores the profound societal importance of herd immunity or community immunity. When vaccination rates are high in the general population, it suppresses the circulation of these diseases. It creates this protective barrier, like an invisible shield, around the most vulnerable people who cannot be safely vaccinated themselves, like very young infants, too young for some vaccines, or the immunocompromised individuals we're talking about. It's a community effort.
Protecting others by protecting yourself.
Okay.
So with all this discussion of incredibly rare events, how exactly do we detect these things in the first place? And maybe even more importantly, how do we maintain public trust in vaccine safety when these rare things do occur?
That's the million-dollar question, isn't it? It relies on having really robust, multi-layered pharmacovigilance systems constantly monitoring safety. First, you have the pre-licensure clinical trials. These identify the common side effects before a vaccine is even approved. But because rare events are, well, rare, these trials, even with tens of thousands of people, simply aren't large enough to reliably detect extremely rare occurrences, things happening maybe 1 in a million times.
Right, you need huge numbers for those.
Exactly. That's where post-marketing surveillance takes over, after the vaccine is in general use. In the U.S., the best-known system is the Vaccine Adverse Event Reporting System, or VAERS. Now, VAERS is a passive surveillance system. What does that mean? It means anyone, a patient, a parent, a doctor, anyone can submit a report of any medical event that happens after vaccination. It doesn't matter if they think the vaccine caused it or not. If it happened afterward, it can be reported. Its strength is its wide net. It's designed to catch any potential new, rare signal that might be out there.
Okay, but you hear so much about VAERS in the news, online, people citing raw numbers from it, and it can sound really scary. What's the catch? Why isn't a VAERS report automatically proof that the vaccine caused the problem?
That is such a crucial point, and it's where so much misunderstanding and, frankly, misinformation comes from. The critical limitation of VAERS is that it cannot determine causality. Cannot. It only documents that event A happened after event B, the vaccination. It doesn't prove B caused A. Many, probably most of these reported events are simply coincidental. Things that would have happened anyway, vaccine or no vaccine. Millions of people get vaccinated every week. Sadly, some of those people will coincidentally have heart attacks, strokes, seizures, develop autoimmune conditions the following day or week, just by chance. Those events get reported to VAERS, but it doesn't mean the vaccine was the cause. The raw data is publicly available, which is great for transparency, but it's very often misused or misrepresented by people who either don't understand or deliberately ignore its limitations. So remember this, a VAERS report is always the beginning of an investigation, never ever the conclusion.
Okay, so VAERS is the smoke detector. It alerts you to potential fires, but it doesn't tell you if it's a real fire or just burnt toast.
That's a great analogy, yes. And that's why active surveillance systems are so vital. They're the firefighters who investigate the alarm. Take the Vaccine Safety Data Link, or VSD. This is a collaboration led by the CDC involving large healthcare organizations. The VSD actively analyzes the electronic health records of millions of people. They can directly compare the rates of specific health problems in people who just got vaccinated versus those who didn't. This allows for rigorous epidemiological studies that can help determine if a vaccine is truly associated with an increased risk, beyond what you'd expect by chance. The FDA's Sentinel initiative, with programs like PRISM and BEST, also uses massive health insurance claims databases for similar powerful active surveillance. And globally, the World Health Organization, WHO, coordinates efforts. And the Global Vaccine Data Network, GVDN, links health data for over 300 million people across nearly 30 countries. This enables the study of extremely rare events on a truly massive scale, which you need for those 1 in a million type signals.
Wow. So if VAERS is the wide-open public tip line, VSD and these other global networks are like the highly skilled detective agencies using big data to investigate those tips and figure out what's really happening. Understanding that two-step process, signal generation, then rigorous investigation seems absolutely vital for interpreting safety data correctly.
It really is. Passive systems like VAERS raise flags. Active systems like VSD conduct the thorough investigation.
Okay. So given all this clear data, these robust surveillance systems, why is there still so much public anxiety, so much misinformation swirling around vaccine safety, especially the neurological aspects?
Yes, it's a persistent challenge. And unfortunately, one of the most impactful drivers of ongoing fear stems from a case of outright scientific fraud. The Wakefield controversy. Maybe you remember it. In 1998, a British doctor, Andrew Wakefield, published a paper in The Lancet, a very prestigious medical journal. It suggested a link between the MMR vaccine and the development of autism and bowel disease. This paper got massive, sensational media attention worldwide.
I remember that. It caused huge panic among parents.
Exactly, huge panic. But subsequent investigations reveal it wasn't just bad science, it was deliberate fraud. Wakefield had falsified data in the paper. He had selectively recruited children for his study. He had a massive undisclosed financial conflict of interest. He was being paid by lawyers who were suing vaccine manufacturers. And he actually held a patent for a rival single measles vaccine he hoped would replace MMR. Plus, he performed unethical invasive procedures like colonoscopies and lumbar punctures on these vulnerable children without proper ethical approval. It was shocking.
That's appalling. Not just bad science, but unethical and financially motivated fraud.
Completely. And numerous large-scale studies since then, involving literally millions of children across the globe, have found absolutely no link between the MMR vaccine and autism. Zero. The Lancet fully retracted Wakefield's paper in 2010, a very serious step. And Wakefield was stripped of his medical license in the UK. But the damage was done. The legacy is catastrophic. Despite being thoroughly, utterly debunked, the myth persists. It directly led to drops in MMR vaccination rates in many countries, and entirely predictable, sometimes deadly, measles outbreaks followed in those communities. It created this deep knowledge debt, this reservoir of fear and misinformation that's incredibly difficult to overcome even decades later.
It's just a tragic example of how scientific misconduct, amplified by media and fear, can have devastating, long-lasting public health consequences. What about controversies that maybe aren't outright fraud like Wakefield's, but are still challenging for public trust? You mentioned HPV earlier.
Right. The HPV vaccine controversy is a more complex example, perhaps. After the HPV vaccine was introduced to prevent cervical cancer and other cancers, reports started emerging. Case reports of conditions like POTS, chronic regional pain syndrome, chronic fatigue, particularly in adolescent girls, after vaccination. Regulatory bodies, like the European Medicines Agency, EMA, investigated these reports thoroughly. They looked at large data sets, and they concluded that the evidence did not support a causal link between the HPV vaccine and these syndromes. However, some advocacy groups and critics argued the investigations weren't thorough enough or that the conditions were missed, fueling public concern and debate.
So a different dynamic than Wakefield, genuine reports of illness, but the large-scale data didn't show the vaccine was the cause.
Exactly. And despite that ongoing debate in some circles, the overwhelming weight of scientific evidence from large independent studies worldwide has consistently found no increased risk of autoimmune or neurological disorders, including POTS or GBS, following HPV vaccination compared to unvaccinated populations. There was even a flawed study in mice claiming neurological damage from the HPV vaccine's adjuvant, which was later retracted due to serious methodological issues. So the HPV situation highlights the difficulty. the difficulty of investigating rare, complex syndromes with varied symptoms, and crucially, the challenge of communicating scientific uncertainty and communicating negative findings. We looked hard and didn't find a link to an anxious public, especially when people are genuinely suffering and looking for answers. It's much harder even without outright fraud muddying the waters.
That's a really powerful point. Communicating no link found is inherently less compelling than a scary headline, even a false one. So given these challenges, fraud, complexity, communication difficulties, what can scientists, clinicians, public health folks do? How can we build and maintain trust in such a sensitive area?
It really comes down to transparent and empathetic risk communication. It's not easy, but it's essential. First, we absolutely must acknowledge rare risks. Be honest, be upfront. Acknowledge that yes, rare but serious adverse events can occur with any effective medical intervention, including vaccines. Denying this possibility, or trying to sweep it under the rug, completely erodes trust when a rare event inevitably does happen. Second, we have to consistently contextualize risk. This is maybe the most important part. Always compare the risk from the vaccine, that tiny, well-monitored risk, to the far, far greater risk of the same or worse outcomes from the natural disease it prevents. The data we discussed earlier, the measles comparison, the flu comparison, the COVID comparison that needs to be front and center, show the difference in scale.
Right, don't just state the vaccine risk in isolation. Compare it.
Precisely. Third, we need to explain the process. Do a better job with public health literacy. Explain how pharmacovigilance works, how VAERS operates, its limitations, how VSD and active surveillance provide the real answers, so the public understands what a report means and, just as importantly, what it doesn't mean. Demystify the process. And finally, I think the scientific and medical community must actively and forcefully confront misinformation directly, especially when it comes from demonstrably fraudulent sources like Wakefield, or when data is being clearly misrepresented. We need to correct the record clearly, calmly, consistently, using accessible language.
Acknowledge, contextualize, explain, and confront. That seems like a solid framework. So our deep dive today, it really affirms this clear kind of dual reality about vaccine neurological effects, doesn't it? On one hand, vaccines are an incredible triumph of public health with an exceptional safety record overall. And on the other hand, rare neurological adverse events, while real and serious for those affected, are exceedingly uncommon.
Absolutely. The evidence we've reviewed is just unequivocal on the main point. For every single known neurological complication we've discussed, GBS, ADEM, encephalitis, stroke risk associated with infection, the risk posed by the natural infection is substantially, often dramatically, higher than the risk from the vaccine designed to prevent it. Vaccination essentially transforms a significant, unpredictable, and often severe risk from disease into a minimal, well-monitored, and extremely rare risk from immunization itself. And for some conditions, like stroke following influenza, vaccination is actually demonstrably protective for neurological health. It reduces your risk. It's truly a testament to decades of scientific advancement and rigorous monitoring.
That transformation of risk is the core message. It really underscores the immense importance of those robust global pharmacovigilance systems we talked about, and the need for transparent, empathetic communication to maintain public trust, which is so fragile. As we look ahead, where does the research go from here?
Well, future research will continue to delve deeper into areas like adversomics, trying to understand if there are genetic markers that might predispose certain individuals to rare adverse events. Understanding the mechanisms even more deeply, which could potentially lead to designing even safer vaccines in the future, if possible. And critically, continuing to research how to improve risk communication. How do we best convey complex benefit-risk information in a world saturated with often conflicting messages? That's a huge ongoing challenge.
Adversomics, deeper mechanisms, better communication, lots still to learn. As you, our listener, reflect on this deep dive today, maybe consider how our collective commitment, our commitment to understanding and transparently communicating scientific evidence, how that shapes not just our individual health decisions, but the very fabric of public trust, and ultimately our community resilience against future health challenges. It really connects us all.
Concierge Care, providing world-class, personalized care for patients and members, taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.